Welcome to the PodDoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we're going to talk about tendon repair. Kind of a cool little case. These are fun to do.
Yeah, a lot of fun to do. Quick, easy. They happen all the time, especially in the lower extremity. I mean, people are always dropping things or, like dropping knives or whatever on their feet.
So, yeah, steak knives, man. Steak knives from 3 feet can do a lot of damage.
Yeah, so that's pretty much exactly what happened. So a patient came in, right? She had I think it was her son's birthday party or something, and I guess doing whatever, she dropped a knife on the top of her foot, and the knife came down right here across her big toe joint. She ended up, feeling
fortunate that it's at that level, because further back she could have done
a lot more damage.
Dorsalis pedis, deep perineal nerve, could have been,
So I did, the full neurological exam, did the range of motion, I did the neurologic, because that's, the ones that cause more problems, the tendons and stuff, we can get rid of nerve problems. Those are a lot harder to treat. So, doing my full exam, boom, right here, cut the extensor hallucis longus tendon. I even got a little video.
Where she's got toe drop. Yeah, there you go.
So
totally.
Thank you, TikTok. This is my little TikTok account.
Oh, so they sutured her up in the ER.
Oh, so did
they know that it was torn?
So I would assume they would attest, but it's an ER. They were probably just rushing through. They didn't realize it, hopefully. But the patient's like, yeah, they sutured me up. They washed it out. It was like a few days out. Everything's kind of healing up now. But the toe, she says,
doesn't work.
Yeah, it's not working. I can't bring my toe up. I feel like it's dragging on the ground. So I was like, all right, so let's get this fixed. Luckily, it was pretty soon after. So tendon repair. So there's 1,000 different ways to repair tendons. Kessel, Becker, Krakow is the one I typically do. Mm-hmm. There's different variations of each, but you want a locking type suture that will help hold the tendon. Because imagine a tendon sort of like we say horsetail, and it's long strands, it's solid, but it's long strands. So if you're running stitch in between and just pulling it through, it's going to end up splitting those long fibers.
Yep.
So our suture style is locking, gripping onto those tendinous fibers and pulling them together. So we'll repair the bulk of the tendon using this gripping type suture, and then depending on how frayed those ends are or how clean those ends meet, we'll do some type of running stitch along them to make sure that it kind of sits nice and flush and doesn't have any type of problems.
Most of those are showing a buried knot technique, except for that augmented Becker.
Yeah.
So and the Suga. So I thought, I think the Krakow or some of the Kessler ones, depending on the tendon, are most helpful because you can bury the knot.
Yeah, there's two trains of thought on that. The buried knot is your gold standard. I mean, you're bringing it in, the tissue will heal around the knot. Yes, you're taking up a portion of that tendon to healing, area, but in the long run, it makes no major difference. The logic behind the knot being on the outside and not in the area of tendon healing is that there's no knot impeding that wound, that tendon laceration site. But then you end up having a knot on the top of your tendon or on the bottom of your tendon, which if you can balance it, great. If you can't, great. So like when I do my Achilles, I'll throw my knots on the side because that tissue, I have some...
You can hide it a little bit.
Yeah, I have a little bit of wiggle room here. But small tendons like this, the suture that we're using, it'll take up minimal space.
And the suture we're talking about is almost indestructible. I mean, it'll tear your gloves before it'll break. So we're using non-absorbable suture material.
So start my incision, right? Dissect it down, a couple of vessels and things run along there. What I'm looking for is the laceration site. So the laceration site is here. You can kind of see on the inside, she's starting to form a little scar tissue, a little granulation tissue. So I'm just kind of buzzing through it so I can keep a nice even plane through that healthy tissue versus that non-healthy tissue. And we want to get down to the level of injury without causing, any further trauma.
That's just perfect.
Yeah.
She just popped it perfectly.
Yeah. And, I was also making sure that the extensor lucis brevis was intact, and which it was. Everything was fine. Just enough to catch that long extensor lucis longus tendon.
And she may have had a partial tear and then ruptured it all the way.
Yeah, so she said she felt a pop So, I mean,
after they repaired it,
I don't know.
Okay.
That's the thing. She said she felt a pop when she dropped the knife, and then she felt a pop. So I think what you're exactly saying. I think she cut like maybe 80-90% of it, and then when she went to move her foot, she probably felt that remaining.
And so we'll give the ER the benefit of the doubt.
Yeah.
That they thought it was attached.
So I'm just making sure I get good exposure, pretty much.
Because we like our ER docs.
Yeah.
We don't want to throw them under the bus.
So here I'm trying to find the tendinous sheath. I'm taking away any of that fibrous tissue or granular tissue.
Yeah.
So it's my little tendon sheath. It's real thin.
It's a good size extensor tendon there.
Yeah. So dissecting up, making sure I can kind of preserve that. It was very thin, so I end up, using a graft instead to help wrap it. But all we're trying to do is make sure we can find both ends, and then obviously resect out the ends that are damaged, because obviously it's not smooth anymore. Well, the nice thing about lacerations are they're a lot smoother than ruptures.
Yeah. You've got a surgical incision, basically.
Yeah, and we told this patient up front, if there's a big gap, I may have to use some type of, cadaveric tendon or something similar, collagen graft or something. But
you can, but if you lose a centimeter with that tendon, it's not that big a deal. They can gain that back with physical therapy. But if you're talking 3 centimeters,
So tendon repair, just like we talked about, we'll go in, we'll bring the tendons back together, and then we'll do like a running stitch over it. And we also want to pay attention to repairing the synovial lining. So the tendon, after we repair it, will have a synovial lining that we violated, right? And we want to make sure that there's no adhesions that will form after we do our surgery, because the last thing you want to do is go and repair a tendon and then end up having adhesions, and then the patient's stuck back in square one.
Right.
So let's get into the tendon repair part.
This is where you're actually going to throw your sutures.
Yeah. So this is after I'm trying to free up the capsule, the tendon sheath. Right. I'm trying to free up the tendon so I can have good healthy ends, and you can kind of see me running up the tendon sheath on both sides, and I'm slowly just dissecting it free, because obviously she's got a little scar tissue, because it's a couple of I think it's like a week or so out, and she's starting to heal already.
And you're planning on you're going to do the Krakow?
Yeah.
Modified Krakow.
Yeah. So we'll use that fiber suture, suture wire, whatever.
Fiber
wire.
Which 2.0 or what do you? 4.0?
I actually don't remember which one I used. I used a smaller one on this one just because the tendon was pretty small. But they're so strong. Honestly, it's just it's honestly like steel cable. It's crazy strong. So dissecting that free. Let's jump ahead. All right, so here's my tendon, right? My tendon. I'm cleaning up the end. Nice flush cut across there. And sometimes what I'll do is I'll use a little needle to kind of hold the tension off of it, so I'm not,
Oh, that's brilliant.
Yeah.
I
learned that from a plastics hands guy.
Nice.
And
okay,
cool. I thought it was wonderful. So now I'm just doing my stitch, not pulling tension on that tendon anymore.
That's brilliant.
So I'll start.
I've never seen that done before.
Yeah, I'll start at the end, and I'll start doing my running locking stitch, and then on both ends of that tendon, I'll have the free suture, and then we'll tie both ends, if that makes sense.
Yep.
So you see, I'm kind of.
So you're locking that, okay.
And I'll try to get at least minimum of 3 on each side. Obviously, if I have more, I can do more. But
that looks like 4.0.
Yeah.
I think that's probably what you got there. So the higher the number, the smaller the suture.
Yeah.
For anybody who's not doing this on a regular basis.
So I'm trying to take nice, little small bundles along the edge. Obviously, you don't want to run it through the entire thing, because then you end up scrunching up the tendon, but you also want enough that you can grab, a good grip off of that tendon. Yep. So I think at this point, I'll start bringing it across. I tried to lace it through, try to zigzag it through the tendon. So if I do it from one end of the tendon to the other, and then that end ends up pinching, but if I run it through the tendon, kind of zigzag it through, I'm able to, keep that tendon laying a little bit more flat. So just do my running, my locking. Let's jump ahead. There we go. Good. I'm on both ends now.
Yep. So you just cut your needle off, and then you've got your
I'm starting the other end. Yep. So we'll do the same thing. We'll duplicate it on both sides. Just gonna, there we go. Zigzagging it through the center of the tendon. preventing it from obviously compressing and causing any type of problems. And then I'll run it down. Run. All right. There we go. All right.
So now you're ready for your hand ties.
So what I typically do, I have my first assist or a scrub tech or someone with me usually. I took out the needle off that that tendon here now because obviously I'm trying to bring it together. I'll run a knot on one side and then I'll have the scrub tech or the first assist do the same thing on the opposite side. So obviously both sides are being brought together, and then with very low tension, I'll obviously be able to knot it. So here it looked like it was kind of pulling, so a little hemostat to kind of hold that knot from slipping. There we go.
Nice.
Yep. So some simple hand ties. And then we're doing both sides. Now you can see obviously the ends are brought together, but they're not perfectly smooth, and there's kind of some frays and stuff in there. So then we do our next thing where we bring the suture. Or I usually use some type of absorbable suture at this part, and I'll start approximating that end to make sure that that lays nice and flat. So we brought this suture together, the tendon together. Now I'm going to do my running epitendinous suture to make sure that that lays nice and flush. You can do running locking, you can do baseball stitch, you can do whatever type of zigzag pattern you want to do, as long as it lays flat. On larger tendon, I'll run it completely around the tendon. On this one, I think I only ran it up one side just because the tendon's a lot flatter. And that will hopefully make sure that I don't have any type of problems. And then after that, I'll go to my sheath repair.
Right.
And in this case, I end up using a graft just to kind of prevent the adhesions. I use like a little umbilical cord graft, stem cell graft, or whatever you want to call it. All right, so now I'm starting to do the small work.
So here's your
So
epitendinous.
Yeah, I think this is a 3.0 or 4.0 vicryl, most likely 4.0, and I think I already ran past it. Let's go backwards. All right, so I'm running my suture across there, zipping through that superficial layer, and making sure that there's no lumps and bumps on there. And then I'll pass it all the way back around and tie it back to that initial site that I have. I leave a little tag for myself so I know that I'm coming all the way back around. And hopefully that'll make that tendon lie nice and flat so no longer feel that little bump from the initial injury. Yeah.
Very nice. We need some good closing music. Do a little.
Yeah, I was trying to see where I can leave that knot without it being too prominent, and trying to make sure in the end the patient feels like I never did anything. All right, let's jump ahead. So this is a little graft I use. We wash it out and everything. A little graft I use. And I'm cutting a slit to make sure it kind of fits around that tendon. I'm not trying to dissect the tendon more than I need to. And
nice.
Yeah.
Yeah, so the umbilical cord grafts will last about 4 months. They'll protect the tendon from adhesions. They'll provide growth factors. There's no true stem cells in them because it's dehydrated.
Yeah.
But they do provide the matrix components of good healing, and so that's going to really do a good job of protecting the tendon and the tendon sheath while things are scarring in.
Yeah, sometimes I'll tag these down. In this case, I didn't, just because there was so much graft. I was like, well, it's barely going to be a problem. And then I'll go to my closure pretty much. So I'm using a 4.0 vicryl here, reapproximating my incision, just making sure that the lines line up nice. I put little hash marks on there, obviously, so I can kind of keep my incision from shifting when I'm healing. And in the end, you want it to look like you never did anything.
I'm looking good.
So let's jump ahead. What is this? All right, so
and you're doing a intro.
Yeah, subcuticular. I use monocryl for mine. I know people like to use different things. This is 5-0 monocryl, and I'll run it through. Obviously, they'll never have any type of stitch removal because these are absorbable. So I'll leave tags on either end. So let's jump ahead. So I'm finishing off here, right? And I'll try to leave a tag on either end where I do my stitch. Some people, will bury the knots. I do mine superficially, and usually around that 3-week mark or 4-week mark, those stitches kind of absorb out, and those tags kind of fall off. There's, 1,000 different ways to do this. This is just a style that's,
Do you steri strip that as well?
Of course. Yeah.
Just reinforce the skin. It looks really good.
Yeah.
I'm sure she'll be very happy with that, and she'll be able to move her toe.
So Lamassazole, I think it's got some steries. There we go, some steri strips. And in the end, she'll have a new functioning toe all over again. Maybe a little physical therapy to help keep that gliding. I mean, I think she's 2-3 weeks out now. So she's doing her light range of motion exercises at home. Some people put wires and stuff across these. I'm not a fan of those. I like to, active range of motion, active range of motion after these.
I agree.
Little iodine. All right.
Very nice.
And then recovery. I put them in a boot just so she doesn't do anything too exertional and pop those. Some people, like I said, like to do wires. There's like splints and stuff for them. You can do a surgical shoe. I do boots. I just think it's easier to walk in, honestly. And she'll hopefully have a functioning toe, no longer dragging on the carpet when she's walking. Nice.
Very good. Dr. Hussain, thank you for that. That's a great case. The dangers of dropping steak knives on your foot.
Yeah.
I think this lady's going to do really well and be very glad that she took care of it appropriately.
Yeah.
So that is it for tendon repair. And we will see you guys next time on the PodDoctors.